Some of the statistics out there is that when you're placing people in like any type of transportation to travel them up to a different hospital, you're increasing their mortality, and that is a statistic. It's nothing changed. We're also cutting our OB beds in half. Currently, we actually have 4 OB beds, 2 at each site, and now we will be going down to 2 OB beds with a geographical area that is covering beyond 50 kilometers.
How is this new model going to save us on costs when you already have a labor unit and staff that is skilled and I'm sure more than willing to continue providing these services for their community at their hospital?
In your opinion, does one site draw the family docs more than the other? Why have we all read a letter from the entire medical staff in Bracebridge this week disapproving?
Many concerns voiced during Huntsville's leg of the MAHC community meetings last week regarding the new Made in Muskoka healthcare plan unveiled to the public. The full house at the Active Living Center listened attentively and respectfully during the initial presentation of details, and then asked many thoughtful questions regarding their concerns on how especially changes to the Bracebridge site would impact local healthcare services. I caught up with CEO Cheryl Harrison following this meeting to get some of those questions answered myself, including the biggest concern that acute care is being pulled from Bracebridge specifically.
Well, it really isn't the case. Both hospitals are acute care facilities. We are providing focused care services at both sites, and so that may be perceived as losing something, but we do need to remember that we are one organization with 2 sites. Focusing care services at our different sites reduces duplication. It makes it affordable not only to build these 2 hospitals, but frankly to be able to operate them in the future. We haven't been able to operate the status quo model that's what we do today. It's been very difficult because we don't have the critical mass when you're dividing services across 2 organizations.
And when it comes to the number of beds at each site, Harrison says the focus shouldn't be on how many beds are available, but instead how to ensure patients aren't spending a huge amount of time recovering in hospital in the first place.
You know, it's a trend in healthcare that we've been seeing probably over the last at least 5 years when it comes to building new hospitals and really asking ourselves, are there things we can be doing differently so people don't have to be in hospital? And there's a lot of, not just it's about the money, but about what's better for the patient. So absolutely the trend in healthcare is, in 10 years, who knows, we may be looking at turning some of our inpatient beds into more ambulatory care services because the technology's out there and they don't need to come into hospital to monitor their cardiac rhythm. That already happens. We're always going to need acute care beds, but the more that we have those care services focused and concentrated means that we have the specialty providers around them. And so, it really is a trend, and we're being held accountable to make sure we're spending the tax dollars wisely, and wasting it because we have to have a certain amount of a standard of how many staff for both sites for some of these specialty services is a draw on the organization operationally.
Now, last week, Dr. Rohit Gupta, who is calling for this plan to change in South Muskoka, told me that MAHC should be pushing on the province to provide more funds needed to expand services beyond this current plan.
I think overall, this model will not save any money. It might be a small save of some money saved with a construction point, but not overall. That's what we think. As far as what should we do, I think the message is loud and clear that if the money is not enough, then the ministry needs to look into it and have more money rather than just saying, okay, we don't have money, just work in that. Just get more money, or ministry needs to get involved.
Harrison says that comes with the danger of either being pushed back in priority for funding or losing funding altogether.
I'll be completely honest with you, James, it is a risk. There, as I mentioned in my presentation, we're not alone. There's at least 6 hospitals in the same boat in terms of the size of project, being close to $1 billion in the province, that are over budget and are sitting, waiting to hear and going back and working on things so that their proposal can go in and they can continue on the line. I think that submitting a budget that is 50% over we've been told clearly these projects, we don't have the money. And that's all the projects in Ontario, not just hospitals. I mean, the Infrastructure Ontario is really struggling with all of these redevelopments, and especially with hospitals. So there is a risk. You know, if we come up with something that's innovative, affordable, sustainable for the future, shows that we can attract and retain professionals, I think that they're going to have the appetite to make sure that we're moving along in the schedule.
Finally, Harrison says it's important to remember that while MAHC has the title Muskoka in its name, that doesn't mean Muskoka is the only community being served by these hospitals, which needs to be taken into consideration with the site plan details as well.
If you were to take the catchment area, and we're looking at actually a map that we can share with people to show that concept, because this is, we are servicing the area to the north, up in Sundridge and Algonquin. We've got coverage right over into Algonquin. When you think about it, if you take Highway 60 to Algonquin Park, the next hospital directly east of us is Barry's Bay, and it's certainly not the same level of hospital. So, and then, you know, to the west north with Parry Sound as well. And so you add that up, and if you put it on a map, actually, you know, Huntsville is probably more central. It certainly shouldn't be about, you know, the them and us. And I really hope that people can rise above that and look at, we're one organization, we've got 2 hospitals, we've got a community. There's so many people that are doing these redevelopments that only have one site. And as I said in my presentation, when they have to find 60% of the overage, they're looking at cutting services or reducing services. We're in a position that we're not losing a thing. In fact, we're gaining.